I'm Craig Larson, Executive Director at the Chronic Disease Prevention Alliance of Canada for CDPAC. I'll be moderating today's webinar. CDPAC is an alliance of Canada's major national health organizations sharing a common vision for an integrated system of research, surveillance, policies, and programs for the promotion of healthy living and the prevention of chronic diseases. To learn more about CDPAC, you can check out our website and connect with us on our Twitter, Facebook, and YouTube channels listed at the bottom of this slide. Today's webinar, titled How Does Food Insecurity Relate to Health and What Are the Implications for Healthcare Providers, is the third in a series being co-hosted by CDPAC and Valerie Tarasek, Principal Investigator of the PROOF Project at the University of Toronto. Today's webinar is intended to bring together practitioners, policymakers, and other stakeholders in healthy living and chronic disease prevention to learn about the results of the PROOF Project and to continue the dialogue on how you can put the evidence into action in your own jurisdiction. And now it's my pleasure to introduce our first speakers, Valerie Tarasek, Professor at the University of Toronto and Principal Investigator of the PROOF Project, and Lynn McIntyre, Professor at University of Calgary and a member of the PROOF team. After we hear from Val and Lynn, we'll hear from Carlotta Basualdo-Hammond, Executive Director of Nutrition Services at Alberta Health Services. So over to you, Val and Lynn.
First, just want to say welcome to everybody. This is the third in a series. So it had started being one webinar. We're now on number 3, and we are delighted to have so many people joining us. The other 2 webinars, as you probably already know, have been posted online. So if you haven't taken them in, please take a look at them, as they kind of are the background to what we're doing today. We started by talking about the measurement of food insecurity in Canada and the interpretation of the numbers that we've been generating on food insecurity in the first webinar. The second one talked about the social and economic conditions that associate with food insecurity, so what drives vulnerability and what we've come to understand decreases vulnerability to food insecurity. And this third and final webinar in this series is a look at the relationship between food insecurity and health and what's known in terms of the implications, or what we've come to understand as the implications for healthcare providers with respect to this problem. So to get started, I'm just going to review briefly the measurement of food insecurity, because everything that we say in this webinar is predicated on a particular definition of food insecurity that comes from this 18-item module that's being used to measure food insecurity in Canada. I offer this to you just because we keep seeing a lot of different definitions and understandings of food insecurity out there. We want to make sure that you understand that as we use the term food insecurity in this webinar, what we're talking about is people struggling to afford the food that they need. And that is measured in a very systematic way through a series of questions ranging from people worrying about not having enough food through to compromises in quality, so not being able to afford balanced meals, and on through a whole series of questions about quantitative deprivation, so skipping meals, cutting the size of meals, going hungry without eating, and finally going whole days without eating, always because of there not being enough money in the household for food. Here you see the results that we have for Canada overall. We only have 4 years of comprehensive nationally representative data on food insecurity. But what you can see from these 4 years is a couple of things, right? The prevalence of food insecurity is high, and it's been rising. To translate this number of households into units that might make more sense to you, by our best estimate in 2012, 12.6% of Canadian households reported some level of food insecurity. That means over 4 million Canadians, and an increase of more than 600,000 since 2007. So this problem is big, and it's going in the wrong direction. Important for you to recognize with this 2012 number is we don't have we won't have nationally representative data again until we gain access to the data for 2017 and 2018. Those are the next 2 years when this measure of food insecurity has been run nationally. While there are measures for some provinces in the intervening years, it will be a couple more years before we're reporting, or at least 1 more year before we're able to report a more current statistic. The understanding that we have of the relationship between food insecurity and health is encapsulated in this very simple graphic. And what we'll do in this webinar is try to peel it apart. We know from the research that we and others have done that food insecurity is associated with dietary compromise, but also with extraordinary levels of stress, and that in fact food insecurity is a measure of pervasive deprivation in a household. And with that, we have seen many, many pieces of evidence suggesting that food insecurity erodes health and it compromises people's ability to manage chronic conditions. So this is kind of the overview of where we plan to head today in this webinar. I want to start, though, by talking about what we know about dietary intake and food insecurity. Our best understanding of this, or our best window into this, comes from the 2004 Canadian Community Health Survey. That was the year when we had a nationally representative survey. Well, I say nationally representative, and I have to stop and point out that the survey didn't include people in the territories. So it was a large survey of dietary intakes at the population level for the 10 provinces, a sample of about 35,000 Canadians. The analysis of that survey enabled us to take a look at what dietary intake looks like in the context of food insecurity. We'll be able to update these statistics eventually because this particular survey was repeated in 2015, but to date that information hasn't been released. So here's what we've learned from 2004. First of all, in this national survey for 2004, we saw little evidence of nutrient inadequacies among young children. And it didn't matter whether they were in food insecure situations or not. The picture overall for young children in Canada was one of relatively limited indications of nutritional compromise. However, when we looked at adults and adolescents in food insecure situations, there were many, many indications that food insecurity was associated with compromises in dietary quality. And our examination of dietary quality from that survey was us looking at food categories defined by Canada's Food Guide and comparing how people stacked up when they were in food insecure or food secure circumstances. And you can see here that we found significant differences based on milk products, fruits and vegetables, and some other food groups, particularly meats and alternatives. When we translated that into the adequacy of the nutrient intakes of adolescents and adults, there were many, many incidents where we found higher risks of inadequate intake amongst people in food insecure situations. So particularly for nutrients like protein, vitamin A, folate, magnesium, phosphorus, zinc, iron, vitamin B6, and vitamin B12. So a broad spectrum of micronutrients for which people in food insecure situations were less likely to be having optimal intakes. To take a closer look at these data, here you see the results for fruit and vegetable consumption for children. And looking across the spectrum of ages, and you can see the M&F are dividing between males and females across different age groups. And the paler purple bar are people who are food secure. The dark one is food insecure. And what you can see is that, you know, on average, the intake levels are fairly close. The stars indicate some significant differences where people in food insecure situations had significantly lower intakes, but the differences are fairly subtle. Now, with the red bar, what you're seeing is how these intakes compare to recommended intakes, and these are recommendations based on the old Canada's Food Guide. And again, you know, we can see what we've all come to understand is taken for granted around nutrition in Canada, that fruit and vegetable consumption is suboptimal. Most of us are not consuming what's recommended, and that was true across the spectrum here for children. But there are differences by food security status. Here you see the same results for adults and adolescents or adults in food insecure and food secure situations. And again, most of us are not achieving the recommendations, but there are some subtle differences. Just to emphasize those subtle differences, I've taken away the red bar now, and you can see that in where we do see effects, we see significantly lower intakes amongst people in food insecure situations. That's fruits and vegetables, and a similar pattern more or less appears if we were to show you the data for milk and milk alternates, so suggesting that people in food insecure situations are less able to afford what we think of as highly nutritious foods. Okay, but take a look at this. Here are the results for sodium. So what you're seeing in this bar is just average sodium intakes for food secure and food insecure older children and adults. And the bars are very, very close together. There are a couple of A's and B's here, and what they're signaling is where we've got a significant difference. But where we've got significant differences, we only have 3 of them. So men 31 to 50, women 31 to 50, and men 51 to 70. We see significant differences between the food secure and the food insecure. But look at the direction of the differences. Now we've got food insecure people having on average lower sodium intakes. I offer you the sodium data to make the point that that we don't have evidence from the Canadian Community Health Survey that people in food insecure situations are more likely to be consuming processed foods or making less nutritious choices. From the fruit and vegetable data that I showed you, we can say that they're less likely to consume highly, recommended foods like fruits and vegetables. They have somewhat lower intakes. But if we use sodium as a marker of processed food consumption, which I think it's a fairly good one of, what you can see is there's no indication that people in food insecure situations are making poor dietary choices. From what we can figure out, they're less able to afford good foods, but they're not people that are necessarily more likely to be consuming bad foods. All Canadians have got a problem with things like sodium, and it's not specific to people who are food insecure. This is more recent work that Sharon Kirkpatrick and others did using data from the Canadian Community Health Survey. So these are summaries of the prevalence of inadequate intakes for individuals now 9 years of age and older. So merging the data or pooling the data for children from 9 years of age up, plus adults and older adults. And again, we've got bars now, a new color, the dark red food secure, the paler ones food insecure. And you can see that for some nutrients, notably here vitamin A, calcium, magnesium, zinc, and to a lesser extent folate, where there are prevalences of inadequacy in our population, people living in food insecure situations have a somewhat higher prevalence of inadequacy. I should flag for you here that the measure of food insecurity that was used in this study followed the USDA definition of food insecurity, so it's a more stringent measure than we've been using typically in the work we've been producing out of proof. So, but making the point that people in food insecure situations have a higher likelihood of inadequate nutrient intakes for a number of nutrients of key public health concern. This study was done, though, to compare our results to those in the United States. And here you see the results for Canada and the United States put together. So the blue bars are the Americans. And you can see marked differences. If we just take a look at vitamin C, overall the prevalence of inadequate intakes for vitamin C in Canada is substantially lower than it is for Americans. But the differences between the food secure and food insecure are also quite different between these two countries. The big differences here, and I'm just going to circle them so you can see them, are with respect to calcium and magnesium. For those two nutrients in Canada, we see very, very significant differences between people in food secure and food insecure circumstances. But in the United States, there are no such differences. There are also differences in the gaps in other places here on this graph, but the big, highly significant differences are those for calcium and magnesium. I offer you this partly to make the point that the findings that we're seeing in terms of the dietary manifestations of food insecurity appear to be context specific. So the research that we're doing in Canada on this topic, both through things like the large Canadian Community Health Surveys, but also through smaller studies in Canada, are very important. We can't simply import data from the United States and assume that it reflects the circumstances in Canada. With respect to diet, at least, it does not, and that's what Sharon's work on this survey shows. You might wonder what's behind the discrepancy between the results we're seeing for Canada and the United States, and that certainly is the subject for a whole lot more research to come. One thing that Sharon was able to do in this study is take a look at the United States food assistance programs. So you know that they have food stamps and WIC and school feeding programs. So they have a number of federally funded public food assistance programs that transfer quite a lot of resources. Insofar as we were able to take into account someone's eligibility for those programs, it did not appear to explain the differences that we're seeing here. So it looks like it's more complicated than simply saying, yeah, well, the Americans are doing better for things like calcium and magnesium because they've got a national school lunch program. That doesn't look like it's the explanation, but much, much more research is needed to understand this. The takeaway message for now, though, two things. Food insecurity is a potent marker of nutrition inequities or nutrient inadequacies in our country, and differences between Canada and the United States mean that we should take with a grain of salt research on food insecurity and diet in the United States, not wholesale importation of that research as if it indicates Canadian evidence. I want to move briefly, though, to flag a bit of more recent research. The research that we have on dietary quality and food insecurity in Canada is from 2004, and that was a while ago, and that's population-level data that omits the territories. More recently, we've seen a number of studies from a number of vulnerable populations suggesting that food insecurity is taking a much bigger toll on people's health and well-being. One of the most compelling ones, I think, is a paper that was published a few years ago in the Canadian Journal of Public Health, reporting on several measures of nutritional status for a group of children living in Nunavik in northern Quebec. About half of the children in that study were living in households that were considered food insecure. And the children in food insecure households were more likely to have lower levels of hemoglobin and to be shorter. Even after these researchers took into account age and sex and other things to consider in relationship to stature, they found that children in food insecure situations on average were about 2 centimeters shorter. So this is a very worrisome indication that food insecurity amongst particularly vulnerable pockets of our population is having a very, very substantial impact on health and well-being, in this case in young children, and taking a real serious toll on nutritional status. Briefly, I want to speak now to the relationship between food insecurity and body weight. And for that, I'm going to go back to data from 2004, because the Canadian Community Health Survey from 2004 is the largest population representative sample we have with measured heights and weights. And anyone who knows anything about the assessment of overweight and obesity knows that it is extremely important to work with measurements. People misreport their height and weight if asked, and so the most accurate window into this problem comes from measures. Here you see the results, again, pooling age groups, so looking at respondents from 12 years of age and older, breaking them up by sex. So we've got the total population divided by food secure and food insecure, and this is measuring food insecurity using a fairly conservative threshold. And then it's broken down for males and females. The E above the bar for the food insecure males speaks to the statistical uncertainty of that estimate because there weren't that many males who were obese, who were food insecure, and so there's some uncertainty about the estimate, but the big picture is that those rates are fairly similar, but there's a slightly higher rate of obesity amongst women or females in food insecure situations compared to food secure. The authors did a number of analyses to further explore these findings, and one of the analyses was to take into account other sociodemographic factors that we know to be associated with the likelihood of obesity, specifically age, income, education, other sociodemographic factors that are kind of social determinants of health and known to link. When they did that and they ran statistics on the differences in the rates of obesity between people in food secure and food insecure circumstances, there was no significant difference. So once they took into account these other factors, even the females that on this graph look like they have a higher rate of obesity did not actually have a higher rate that was associated with their food security status. They delved more deeply into the measure and reported an elevated odds of food insecurity among women in one category of food insecurity. Now, they were using a U.S. Set of thresholds, so it's not the same as the terms we use now in Canada, but it suggests that there was a small increase in the probability of obesity for women in moderately food insecure situations only. But there's nothing from the analysis of these authors using the very best data that we up till now have available on the relationship between body weight and food insecurity. There's nothing to suggest that obesity in Canada is a problem of food insecurity. those findings are consistent with the literature more broadly. There have been a number of studies done in the United States to look at the relationship between food insecurity and body weight, and wherever there is a finding, it typically is an association between the higher probability of obesity amongst some groups of adult women in relationship to food insecurity, but typically no significant findings for men or for children. It's important to recognize the limitations of this burgeoning literature on food insecurity and body mass index. First of all, the measures of almost all of us are cross-sectional. So we are looking at food insecurity measured at over a 12-month period and relating it to a body mass index that maybe has taken 40 or 50 years to produce. So it's a cross-sectional measure. Most of the literature is using self-reported height and weight data, which we know are biased. There are problems of confounding in that not always are people able to take into account things like parity, which we know associates with the likelihood of excess body weight amongst women, chronic ill health, and other variables. So the associations that have been reported even for adult women are far from definitive. There have been a couple of prospective studies done in the United States where people have followed women over time, measuring their food insecurity status and their body weight. And those two studies, I mean, I only am citing two here. There may be more out that I'm unaware of. But the evidence to date that is prospective shows no evidence that being food insecure causes weight gain. So where there are associations for adult women, like the association that was ultimately found in the analysis of the 2004 data in Canada, there's nothing to suggest that food insecurity is an obesogenic condition.
So let's now look at health and chronic conditions more broadly. Now, we began our webinar by suggesting that food insecurity, in fact, is related to many negative health outcomes across the life cycle, but this slide is a little bit misleading because we actually don't have good information on all of these demographic groups, and we'll take what we have and tell you where we need to have more information. Let's look at food insecurity on pregnancy, birth outcomes, and early life, and this is a relatively new area, particularly in Canada. So far we have some very interesting, solid, qualitative research that has been associated with food insecurity being associated with early cessation of breastfeeding, and for women who can't breastfeed their babies, real struggles and inability to afford formula. There is actually no other information, though, yet on pregnancy, birth outcomes, and very early life health outcomes for children. When we look at the United States, there have been some this important work that actually is a bit disturbing. So there have been pregnancy complications associated with food insecurity, low birth weight, and Carmichael's study on birth defects, particularly complex birth defects, including anencephaly, even when she corrected for folate, was also, again, worrisome. Poorer health and increased likelihood of hospitalization, and then some early childhood development compromise has been found. So we don't know how these results translate to Canada, but they are certainly an area of future concern. What we do have is from our own work in the National Longitudinal Survey of Children and Youth, and this is a study which followed up to 16 years. Children from birth or very early childhood up until they were adolescents or even early adults. And so I think when we've talked about this survey in the past, we always have to remind you that the only question that was asked in 1992 and first administered in 94 was, has your child experienced being hungry because there's no food in the house or money to buy food. So this is actually the characterization of very severe child-level food insecurity. And 3 studies have been published on the long-term follow-up on this hunger experience. And overall, there was poorer health among children and youth in 10 to 16 years of follow-up. That if the child had repeated episodes, that meant you came back every couple of years and you found the family was still in the same situation. Those children had higher odds of chronic conditions, including asthma. Very concerning as well is that the experience of child hunger predicted in late adolescence and early adulthood that they would report depression and even suicidal ideation. And then just in the last couple of weeks, this last study has come out, and it basically actually goes farther in the depression story. So not only is there a higher likelihood of depression occurring in after 16 years of follow-up in those that experience childhood hunger, that depression is more persistent. And that means that when we look at the pattern of early adolescence to late adolescence, you often see higher depression rates among the early adolescents, and there seems to be, as they get towards early adulthood, a lessening, where it's actually a pretty fixed state in this population. And it may contribute to the information that we have about biological embedding or the changes in the brain that might occur from the experience of and the stress associated with hunger in childhood. We certainly have much more plentiful and robust data about health in adults aged 18 to 64. So here's just unpublished, but it starts the story. Those that report poor or fair self-rated health, those that report poor or fair self-rated mental health, and those that are reporting life stress, they are absolutely showing an increase in a graded fashion between the food secure, which is the lower bars, and the severely food insecure. So it's not only the severely food insecure that have very, very high rates of poor health reporting for self-reported health or mental health or life stress, but it is those marginal and moderately insecure groups as well. So major points here. This is very much predictive of the experience of poor health, physical and mental, and stress. It comes in a gradient fashion, and for those with severe food insecurity, it's very much higher than those that are food secure. So this pervasiveness, I think that we're going to try to point out to you, is related to both diet-sensitive and not as diet-sensitive chronic conditions. And here's just an example from the Canadian Community Health Survey, which only asks about the health conditions that are in the box. And they're asking for people to talk about physician-diagnosed conditions, and they've persisted for at least 6 months. So the first story here is, again, very strong gradient of those with severe food insecurity versus marginal and moderate. You see more with the more comorbidities of having more health conditions that are chronic. And this is just, again, just to show the kind of pervasive burden of chronic conditions that can be found among the food insecure. If you need to see specifics, then we're going to take you through a couple of slides that can show you the kinds of conditions that have been studied. And again, here we have heart disease, diabetes, and hypertension. They're all arguably diet sensitive, but of course they're all as well very prone to respond to chronic stress. And so here you see some differences between men and women, and particular vulnerabilities of men who are severely food insecure. But the story is, again, of importance of severity of food insecurity and importance of a gradient. So here we're seeing a combination of not so diet sensitive, asthma, back problems, arthritis, and then a mental health condition. And again, you see very, very high gradient effects by severity of food insecurity. Men and women both having responding to this, and again, a kind of a differential burden of chronic conditions all over the map associated with food insecurity. Now, if you look at the mood disorders just in the end, I just want to now point out one of the newer areas of intense research is the examination of mental health and food insecurity. And so here you are seeing among the women this astounding 50% of severely food insecure women in Canadian Community Health Survey have had a physician diagnosis of a mood or anxiety disorder, and fully a quarter of the men have had that. And if we know the difference between the reasons why men are less likely to be diagnosed or to report, this is actually, again, a very, very important warning sign. So the next slide is under review, waiting any minute. It's the work that we've done on, again, looking at 6 adverse mental health conditions that are reported in the household food insecurity with that module for many pools. So from 2005 to 2012, so we've got very big numbers here that we can actually look at. And so we've got conditions from depressive thoughts in the past months to major depressive episodes, to fair or poor mental health, to suicidal thoughts. And consistently, you see much higher rates as you increase your level of food insecurity, and to the area of being very alarming. So this is why there's this new attention to adverse mental health and food insecurity. So it actually gets more interesting and more complex as one tries to tease out, is it that you are in this food insecure state and that kind of a stressor is leading you to mental illness? Or is it perhaps that mental illness is so debilitating and the coping in poverty is so challenging that you actually become food insecure? And the answer is yes, both. It does appear that food insecurity and mental health are bidirectional, and we are probably going to be finding other chronic conditions are bidirectional as we move through other chronic conditions. So just quickly on the evidence. Heflin, and for those of you that knew about the Proof conference, she was there as well. So this lovely study, it's several years old now, but basically taking female welfare recipients in Michigan, 1997, follow them for 3 years. In the beginning, some are food insecure, follow them up, and they end up having higher rates of mental illness. In the beginning, some are mentally ill, have mental illness or conditions diagnosed, follow them up for 3 years, and significantly more are food insecure. So it's one of the studies that genuinely shows this bidirectionality. But I wanted to point out the next 2 studies, because that's US stuff. I mean, I think we have to take their material deprivation as being somewhat different than elsewhere. But even in Britain, they were able to show this kind of counterintuitive finding when we usually think that food insecurity precedes mental illness because it is such a stressor. In these 2 studies, including one from Britain, it was in fact the mental health that preceded the food insecurity. And again, that was such a debilitating experience that you couldn't actually cope with resources, to acquire enough resources to maintain food security. All right, so that's sort of the big picture on this pervasive effect on physical and mental health. But food insecurity, and Carlotta is going to come to this even more, is actually also a stressor for being able to manage those chronic conditions that you have. So just going to take a few of these exemplars. So unfortunately, but not surprisingly, HIV status is not captured by the Canadian Community Health Survey. So the studies we have on HIV and how the disease status is affected by the context of food insecurity come from work like we're presenting here done in British Columbia. So we're seeing from that big BC cohort, we're seeing up to 70% prevalence rates of food insecurity among the HIV positive individuals that they have in their cohorts. We've seen systematic reviews coming out of this, the AIDS groups as well, that are showing really genuine effects on disease status. And here we're using the lower CD4 counts. Some studies are looking at viral load, so that the food insecurity, in fact, has tangible adverse effects on immune system, resiliency. And then just follow for 13 years, HIV positive injection drug users, very vulnerable group. Some are food insecure, some are not. And you see a 2-fold mortality. And we're still going to, some of the work of Proof is now ongoing, looking at mortality. But here's the first sort of example of even in this vulnerability, that differential vulnerability can actually create, very serious outcomes. So more well-known and more prevalent, of course, is the story of diabetes management in the context of food insecurity. We have Nova Scotia children's results to show that insulin-dependent children in Nova Scotia are more likely to be hospitalized when their family situation is food insecure compared to others. We have an adults, poor self-care among Canadian adults with diabetes as a Canadian finding among the food insecure. And the US has been able to populate the literature with really adverse outcomes frequent hypoglycemia, poor self-management, health services, increased use of physician services. So very important. Diabetes is a highly diet-sensitive condition. It's an expensive condition to manage, over time, and we are seeing that this vulnerable population has difficulty managing. Little bit of work has been done on another condition like chronic kidney disease. Of course, the antecedents of chronic kidney disease are often diabetes or hypertension, but a U.S. study came out a few years ago to show that there's a big differential in chronic disease outcome. And so the implication of disease progression, dialysis, I know the Canadian Kidney Foundation is very concerned around the impoverishment of its chronic kidney disease population and whether or not that impoverishment of having chronic kidney disease is more likely to lead to dialysis and other poor outcomes among its members.
Just briefly now, we want to turn to have a conversation about the effects of food insecurity on healthcare costs. Everything that Lynn's been saying about the relationship between food insecurity and health and chronic disease management has implications for healthcare utilization. A couple of years ago, we did a piece of work looking at the healthcare costs associated with food insecurity among adults, working-aged adults in Ontario, so 18 to 64-year-olds. Basically what we did and what we were able to do with data from Ontario is link their information about food insecurity that comes from the Canadian Community Health Survey with health admin records, so their use of physician services, emergency departments, and all sorts of things that are covered by the public purse in terms of healthcare services. What you're seeing on this graph are the average costs per adult over that 12-month period when their food insecurity status was measured and divided up by severity of food insecurity. And again, you're seeing the gradient. I mean, this gradient was evident in all of the slides that Lynn showed you. It's evident in everything that we do. The more severe the food insecurity, the worse the circumstances. So much so that people in severely food insecure situations have more than double the healthcare costs over the course of a year. These bars have been divided up in terms of the nature of the healthcare utilization that was examined. And I can tell you that irrespective of which category we looked at, we saw this same significant linear trend, whether we were focused on hospitalization or emergency department visits or, physician patient services. Everything we looked at, we saw that there was a steady increase in the probability of using those services and in the costs associated with their use if the more severe the food insecurity was in the household. Around the same time that we were doing this study, another paper came out from a group in Ontario, also looking at Ontario adults and looking at high-cost healthcare use. About 5% of healthcare users account for 2/3 of the total healthcare expenditures in our country, and those are this elite band of people that consume an enormous amount of healthcare. So these researchers did a study to take a look at what predicted who would become a member of that elite 5% that consumes so much healthcare over the course of a year. They looked at a number of measures. This study was not designed to study food insecurity at all. They were looking at neighborhood characteristics and other sorts of socioeconomic variables that were known to associate with health and with healthcare utilization. But I think it was a surprise to them that food insecurity surfaced as the single strongest predictor of who would become a high-cost healthcare user over the subsequent 5 years. What's important in this study is that they start with a group of adults and they take into account their baseline health status as well as their other sociodemographic risk factors, and still food insecurity surfaces as the strongest driver of who will join that elite band of high-cost healthcare users. So this problem of food insecurity, as viewed through the lens of healthcare utilization and healthcare spending, shows a very, very strong impact that suggests that the chronic disease management issues and the healthcare, health status issues that we've described in the earlier parts of this webinar are, significant problems.
So now that we've got you all hyped up about how important this is as a healthcare problem, then we have to take some time now to look at screening for food insecurity, which is also a very hot topic. So I am a dyed-in-the-wool public health physician, and so we care very deeply around about screening and screening programs. So we have throughout the decades, we've been looking at classic criteria for screening programs in public health. And you can read this, but it has to be an important health problem. Who's going to be treated? Do we have facilities for diagnosis? Is there a latent symptomatic stage? The natural history of the condition, etc. So these are the classic criteria for screening in a health setting. And I would submit that only 2 of these 10 criteria are met by food insecurity. It is an important health problem, and by using measures like the Household Food Security Survey module or modifications, we can probably identify who's food insecure. But I would submit we can't answer any of these other questions adequately. So then you tell me, well, the WHO has actually been looking at much more than just disease screening, what other things we should be looking at. So they've actually come up with an enlightened sort of approach to screening. And so they have 10 more types of challenges for screening. So we have to have a screening program that responds to need. The objectives of screening is clear. We know our defined target population. We have scientific evidence that this is an effective program, and you can read the rest. And I would submit that none of these are actually addressed by screening for food insecurity in the way that we would expect it. And then there are more questions. So what tool to use? I mean, there is an 18-item instrument, and it takes about 5 minutes to use. We also have the many 2-item subsets, and so for those of you who have been watching the literature on the 2 items that have been recommended, Gunderson has actually looked at other sort of 2-item ones that are derivations, and they seem to be fine as well. Okay, so then the other important question is who should do the screening? I mean, is it the ward clerk that does it, or is it actually the provider who can actually immediately use the information? The other aspect of that's really important that we know from food insecurity measurement is that the best measurement, reliable, valid, and highest rates are from face-to-face administration and telephone less so, and certainly not self-reports. You certainly don't make somebody just answer a little questionnaire. And then the final aspect is if we've given you any message today about the importance of food insecurity and health, it's how important severe food insecurity is. And if you can't capture severity, you actually are losing a lot of your impetus for action. But by far, the biggest question about screening is what are you going to do about it? Okay, so why is it that we think that screening might be a good idea? So here's a few little thought experiments. So the first thing is that we know that chronic disease is more prevalent among food insecure individuals, and so they're overrepresented in the clinical population. And so here are the data that we showed you in the first webinar from the diabetic clinic, a regular walk-in clinic in Richmond Road, Calgary. And we see that while the population in Alberta at that time had 7.2% moderate or severe food insecurity, in that clinic it was 15% and very high rates of severe. And so the issue of prevalence is that it's higher, but one of the other rules of screening is if your pre-test likelihood is so high, why would you screen? So you have to have actually relatively low rates to make screening meaningful. The second, of course, rage is that one U.S. authority, namely the American Academy of Pediatrics, has come out on we at least need to have screening for children's exposure to household food insecurity. And they argue not only that they had a little 2-item screen, but they also argue that this would help the provider refer parents or the caregivers to the very substantial resource programs for food that exist in the United States, from the nutritional programs or WIC programs. So in Canada, we have no such comparable programs, and no, we do not want such programs. So what do you have to do? You have to refer to a local food bank or other community food programs, and these webinars have told you that they do not yield enough resources to render families not already food insecure. And we have a safety net that is basically income-based in Canada. So another reason to screen is to say, well, you know what, there are a few interventions that we do have, and so one of them would be this special diet allowance for screening social assistance recipients, and that might be a better justification to get it to them. But social assistance recipients, as you'll see on the next slide, are like crazy high, and you saw that in the second webinar. Those are extremely high rates. So the issue is, I mean, what are you looking at here? If we go back one more, who are you trying to find? Everybody's food insecure, so, and they also need to have this disease. So basically, anyone who qualifies for that benefit of social assistance and has the eligible condition should be given the supplement. There is no need to screen for food insecurity. And then the fourth reason is, okay, there's value in screening if you can actually send people and refer them for their entitlements through the income tax, child tax credit, etc. So what we would say to that is all of those are based on income eligibility. So what you need to do is to identify people on the basis of low income. And the question is, you're going to see Carlotta go over, is do you ever have difficulty making ends meet at the end of the month? It's been now being used quite widely. It's got some validity and reliability in terms of sensitive. It's the way that you identify somebody who needs those entitlements, not through the food insecurity. So, and to summarize before we hand it over to Carlotta, is that I think we've shown you that food insecurity is related to dietary inadequacies and dietary inequities. I think it's profound, the health effects that are pervasive, and they certainly extend beyond nutrition-related conditions. The health burden does occur across a gradient of increasing severity, and that is a very burdensome and costly problem. Bidirectionality has been observed in mental health and may in the future be observed for other conditions. Disease management is absolutely impaired, and it does lead likely to worsening of these existing conditions, and that screening remains unwarranted, we would submit, in regular healthcare settings. We have many, many resources at the Proof website, and we invite you to look at that. And now we turn it over to my excellent colleague, Carlotta, who will give us the implications for healthcare providers.
I am the Executive Director for Nutrition Services within Alberta Health Services, and we are a bit unique in Alberta in that we have all dietitians in a centralized provincial department, which includes dietitians who work in both clinical and in public health areas. And we've been on a journey for a number of years to better understand how we can address food insecurity within our health system. We've really been fortunate to have Dr. Lynn McIntyre and other leaders support us in our work, and work's included investigating food insecurity screening tools, including food insecurity screening in a Calgary diabetes program, which Lynn mentioned earlier, partnering with Dr. Anna Farmer and researching dietetic practice and food insecurity, and more recently we've completed reports on the cost and affordability of healthy eating. In the next 10 minutes or so, I hope to share some of our perspectives on the implications of food insecurity within our healthcare system. We do sometimes find there's confusion about food insecurity and how it relates to malnutrition, so I plan to speak to this as well. Dr. Tarasik and Dr. McIntyre so far have really, I think, done a fabulous job describing the numerous health implications of food insecurity, including the relationship to chronic disease and mental health. And in addition, they've described the impact of food insecurity on poor dietary intake and increased risk of nutritional inadequacies. In the healthcare system internationally, recently there's been a huge focus on malnutrition. And although food insecurity and malnutrition are related, they are distinct. And in Canada, food insecurity is really not a significant contributor to malnutrition in our health system. However, there's association, like directly, but there's association between the numerous chronic diseases and mental illness with food insecurity has been described, and this does indirectly contribute to malnutrition. There's been many different definitions of malnutrition, but in healthcare, when we talk about malnutrition, we are really referring to undernutrition. And there's been work internationally to come to some consensus on how we define malnutrition, but in general, we're referring to a decline in lean body mass that leads to functional impairment. The healthcare system, as I mentioned, has focused on malnutrition because of over 30 years of research that's really described the problem of malnutrition in hospitalized patients. So there's been a huge amount of work in this area. And more recently, the Canadian Malnutrition Task Force has published on a study of over 1,000 hospitalized patients and reported that nearly 1 in 2 adult patients admitted to hospital are malnourished, and malnutrition is associated with a longer length of stay and more likely to be readmitted after discharge. So we know that malnutrition negatively impacts patients' recovery, quality of life, and increases healthcare costs. And we've been working towards better detection of malnutrition through screening and improved prevention and treatment of malnutrition. Although there are associations between malnutrition and food insecurity, the risk factors are different, and only a portion of our patients have both malnutrition and food insecurity. How we address both of these issues differs because we need to target the root causes in order to improve patient outcomes. Therefore, the strategies to address these issues differ, and with food insecurity, the cause is mainly due to severe financial constraints, and therefore healthcare providers cannot directly address the issue, but really do need to be aware of this as a barrier to patients in managing their condition. I often hear about food insecurity being an issue for our older population, but this has not been supported by evidence, therefore provides a really good example of the differences between malnutrition or nutrition risk and food insecurity. Data from our Canadian Community Health Survey has shown that seniors who have a pension have a much lower prevalence of food insecurity compared to the other Canadian households. So that pension is protective against food insecurity. And they also have a much lower risk of severe food insecurity. In contrast, there's also been data from the Canadian Community Health Survey data that used Screen2, which is a measure used to identify nutrition risk. And it was found that over a third of Canadian seniors living in private households were at nutrition risk. So malnutrition and nutrition risk for our older adults is really a huge concern. Heather Keller, researcher from Waterloo, developed a Screen2 tool to identify seniors who are at nutrition risk in community settings. And these questions here include key risk factors that contribute to nutrition risk of seniors. And as you can see, issues are more related to access to food than inadequate income to purchase foods. There are health system implications for both food insecurity and malnutrition, and we're most concerned about the implications of severe food insecurity, as has been already mentioned, on having a negative impact on the ability of patients to manage their chronic conditions, such as diabetes and kidney disease as examples. So food insecurity has an impact on a patient's ability to manage a number of health conditions, and for example, patients who do not have sufficient income to pay for equipment required to manage their health condition, or the extra costs needed, such as transportation, it may impact their health, including, for example, their energy or productivity, and this might have an impact on their ability to even access or find financial help. So in order to address food insecurity in the health system, we need to have better ways to identify those who are experiencing food insecurity. As already been mentioned, screening is potentially an option to look at, although we need to think through that very carefully. Although healthcare professionals may believe that they can identify patients through their assessment, we have found that it is important to use a valid, consistent screening tool. And we need screening to identify patients who are both malnourished, and another screening tool probably for those who are food insecure. And as I've already said, to date the focus has been on implementing malnutrition screening, but as Dr. McIntyre shared earlier, there really is an opportunity to think about how we can advocate for screening, for example, looking at poverty as a screen, and potentially use this in different programs like admission to hospital or chronic disease management programs or primary care. Along with screening, it's important that there are appropriate interventions for those who are identified at risk, and clinicians need more understanding about food insecurity and knowledge about what strategies might be helpful for their patients. For malnutrition, we have been recommending the Canadian Nutrition Screening Tool, or CNST, which was developed by the Canadian Malnutrition Task Force. And it's a simple, easy-to-use tool, but even despite this, there's been lots of challenges in getting this implemented. More work is needed on determining what screen would be most appropriate for food insecurity. However, as mentioned, one option is to consider a screen for poverty, such as, do you ever have difficulty making ends meet at the end of the month? This simple type of tool is more likely to be used by healthcare providers and can help identify patients who may be experiencing food insecurity, and it creates an opportunity for further assessment. So what can health providers do? This is a big question, and really a lot more research is needed and work is needed on this. But some ideas are here. Some key points to think about are it's really important to provide care that is patient-centered and to work collaboratively with patients to understand where they're at and what they might find helpful. So we need to assess patients to determine if food insecurity is a problem for them, if it's a barrier to their recovery or managing their disease. And once you know more about their situation, asking the patient, do they want information or education about this? And as applicable, offering appropriate information, perhaps related to submitting taxes or government programs, health benefits or community programs is appropriate, but it really needs to be targeted to what's going to be helpful to that patient. Another key point is to, wherever possible, work as a multidisciplinary team and connect the patients with appropriate services and resources. So some additional opportunities include understand patient and family perspectives on the healthcare system and how it can better care for patients who are experiencing food insecurity. Understanding the prevalence of food insecurity among those accessing health services. So there's already been a lot of work to date on that, but really exploring that further and getting more information about that. Research on poverty screening and the impact of screening on patient care and outcomes is beneficial. And improving education, and really starting with undergraduate education and for other healthcare professionals as well. So in summary, we know that food insecurity is associated with negative health outcomes across the life cycle, and evidence is continuing to emerge about how food insecurity impacts health and cost to the health system. But we really do need collective action to tackle the severe financial constraints that underpin food insecurity, and we need purposeful, evidence-based approaches to screening and understanding healthcare provider roles. So I think what key message I have is I think we all have a role in helping to create awareness among healthcare providers about all this information that's been shared today about how food insecurity impacts health. So lastly, I'd just like to acknowledge my team, Suzanne Gelsi, who's our Population Public Health Nutrition Lead, and Sheila Szymanski, who's our Director for Population Public Health Nutrition Strategy, who work with me on all this activity. So thank you.
Well, thank you, Carlotta. Craig, I'm thinking now we can maybe go to questions if there are some for us.
Yes, Val, there are several really interesting questions. And in fact, I'm going to start with a few that were directed to you, Val. Adele, first of all, there's a statement that Adele said that in 2015, the Saskatchewan Alliance for Youth and Community Wellbeing, they conducted a survey in schools for grades 7 to 12 students. And they found that about 1 in 5 students, or 18%, they say, had experienced hunger as a consequence of a lack of access to food in the house or money to buy food, and that about a third, in fact, a little over a third, students who experienced hunger skipped meals or ate less to cope. And she indicates, Adele has indicated that we can access the provincial report online, and we'll make sure that Bill and I will provide that link with our. We'll add that to the resources online so everybody can see that.
Great.
Now, Anne has said that, or asks that for young children, she says, I understand babies may have breast milk, so I guess food insecurity is not affecting them as much. But why would young children 2 to 12, young children 2 to 12 are not affected by food insecurity either? And do you have any ideas about potential reasons?
I think that we would say that young children are affected by household food insecurity. I mean, if you think about the evidence that I showed where I made the comment that we saw little evidence of an impact on young children, I was speaking only about evidence of nutrient inadequacies. And so that's a very, very extreme measure of, it's only one measure of a problem. But if I think about the really important work that Lynn and her colleagues have done on the National Longitudinal Survey of Children and Youth, I think that says overwhelmingly that children's exposure to food insecurity is a concern. Lynn, maybe do you want to comment on that?
Yeah, I think we should be exactly following that storyline. So it is actually not that expensive. You know, the consumption of this very small child is not that difficult to meet, but we also have overwhelming evidence that parents and older children will be the ones to protect the youngest children from having inadequate intake. So that's also kind of behavioral and protective. But that does not mean that these children are not having adverse effects of the household being constrained in terms of food. And I also wanted to point out that I think we are seeing some pretty worrisome information around even the breastfeeding, that many of the women that are living in very dire circumstances, it's difficult to breastfeed, and it's quite punishing if they need to get formula for their wee babes too. So there's actually nobody that's really protected in these households.
Thanks, Anne and Lynn. We've got a comment and some questions from Mark Andrew. He says that many of the studies cited in this presentation clearly show the association between food insecurity and outcomes such as weight, chronic disease management. But is there sufficient evidence to say that this association is causal? And he goes on to ask, is food insecurity a reliable measure of poverty?
Well, that's an excellent question. It's hard to know where to start in responding to it. I think that you're right to say that any one of these studies doesn't necessarily show evidence of cause and effect, but there is an overwhelming body of literature now pointing to poorer health amongst people in food insecure situations, and a growing number of studies that are prospective by design showing subsequent manifestations of ill health. And I think specifically of the really important work I think that's come out of Lynn's work on the National Longitudinal Survey of Children and Youth. I think that we could in another, not that I'm suggesting another webinar, but it would be interesting at some point to go through something like the Bradford-Hill criteria for causality or causal inference and see how well we fit them. But things like the dose-response effect that we're seeing, I think, also speak to the probability of a causal relationship. The other thing that I would say in response to the question about is food insecurity a valid measure of poverty, I think what we and others have shown is that the measure of household food insecurity that's being run now on the Canadian Community Health Survey is a very, very sensitive measure of material deprivation in households. And it's one that relates to other measures of things like health and well-being, for example, the healthcare cost work. So I think that's fair to say. But Lynn, do you want to add something? Because I'm sure you've got thoughts on this as well.
Well, I mean, obviously we cannot do a randomized controlled trial to assign people to the state of food insecurity. So that's the only evidence that we're not going to have. I do think there's enough in Bradford-Hill to show a causal relationship between the food insecure state and adverse effects in future. From the longitudinal work and from this preponderance of evidence that actually would map against the causal criteria, from dose response to biological plausibility to being consistent and pervasive around these other all these broad health outcomes. But that's why the bidirectionality also now becomes an interesting extra component, that it's not sufficient to talk about this as causal or non-causal, because this is actually a clear mechanism of adversity within the organism. And whether it's what direction it is not as important as the fact that it is quite a toxic stress.
Thanks, Anne and Lynn. Now, Kim has a somewhat related comment and question. She says, is it that food insecurity is causing the associated health outcomes such as asthma, suicidal ideation, or is it that food insecurity is a condition itself of poverty? And is it the poverty that causes these outcomes? She goes, that if the association is presented as being with food insecurity, might there be potential for conflation and a food response instead of an income response as a solution? Does anybody have thoughts on that?
Yeah, well, let me just start. Like every bit of data that we're presenting to you, that is in the modeling is actually also correcting and accounting for other poverty indicators. So I think we've been able to, over the last two webinars, show how absolutely unique this indicator is of material deprivation, over and above, independent of other poverty markers, other low education markers, other income markers. So that is actually not a dispute. This is not a residual confounding story. That this is actually a very unique and independent effect. So I think we can disabuse ourselves of this just being another marker of poverty. The other thing is that it actually has way more sensitivity to income shock, kind of experiences, and you can see these things change, which is what you can't actually see from household income, which is actually a longer term.
And as for the concern that work like the work that we presented in today's webinar would lead to food-based interventions, if you take a look at the webinar that we did, number 2, I think you'll see quite clearly that we have an awful lot of evidence to show now that what moves the needle on food insecurity are income-based interventions, interventions that improve household financial circumstances. We don't have any evidence to suggest that food-based interventions will change the very, very serious levels of deprivation that are being captured with that 18-item food insecurity module. So I understand how just simply using the language food insecurity, conjures up notions of a food-based problem with food-based responses. But I think that if one delves into the literature on this topic at all, it becomes clear very quickly that well, yes, we find people in extreme levels of deprivation by asking them about their ability to meet their food needs. What we're picking up is material deprivation, and what changes that circumstance is financial interventions.
Interesting. That's sort of a perfect segue, Val, to a question from Joanne. She says, is food insecurity defined only by financial limitations? Can you be food insecure due to physical or functional or cognitive issues, such as an inability to grocery shop or prepare meals, or consequences of suffering from dementia?
The way that food insecurity has been measured in the research that we're presenting today doesn't include those conditions. Absolutely, there are people that would experience barriers to meeting their food needs because of things like cognitive impairment. But the questions that are used to identify food insecurity, as we've used the term today, are very much focused on financial constraints. So someone who skipped meals because they were dieting or because they were too busy to eat or because they couldn't get to a store, they wouldn't be captured as in this large, 4 million that we're talking about living in food insecure situations, unless they reported that they had problems accessing food because of financial constraints. So while those situations that have been described are important, they're not what we're talking about when we talk about this measure of food insecurity.
Maybe I'd ask Carlotta, maybe I could just ask Carlotta just to reemphasize the food risk terminology in the way that you actually did it very well.
Trying to think of how to frame that. I guess what I was trying to share as a key message is just identifying risk of poverty then helps explore further with the patient their situation so that you can understand how food insecurity is creating barriers to their ability to manage their chronic condition. And it's really about the conversation with the patient when you're looking at individual work. And so a lot of the work to date with food insecurity has been on a more population basis, and this is where I think further understanding how to understand the experience of patients and their families in food insecure households will be important to understand how we can help them. And knowing that in a healthcare system we can't do it with income-based solutions necessarily, there has to be other ways that we can help them manage.
Well, I also heard, if I might, Craig, just that there are many, many food access risks for individuals that can actually create a vulnerability to malnutrition, for example. And that is not the same as characterization of food insecurity, which we've been very clear for all these webinars and the way it's measured nationally as a surveillance. It's about the lack of access to food because of financial constraint. That is the parameter of the definition.
Great, thanks all. I have a question from Susan that I think is answered by Celeste. Susan had asked, do the food banks do any screening? And Celeste has responded, Susan, yes, we have some health data, including diabetes prevalence among 12,000 people using food banks in Hamilton. So thanks, Celeste, for sharing that. I have a comment and question from Nadia. She says, currently our public health efforts are increasingly being directed towards mental health services, enhancing mental wellness. From what you've described, we should be looking also at food insecurity in our efforts to address mental unwellness. Are there thoughts from any of the three speakers?
Well, I'll take, this is another rage in the American literature is to be screening your mentally ill people or those that come in for mental health services for food insecurity. And the question is absolutely what are you going to do for them? And so I do think that a social history is part of all types of individual care. But this jumping to screening still requires you to meet the criteria for ethical and appropriate screening. And so what shall you do? And if you're just going to be sending them off to get their tax credits all, then you might as well just screen for poverty.
Interesting. And that I'm going to go now to a comment from Kelly, and she's saying she's wondering about the ethical concerns around screening for food insecurity and or poverty if we don't have appropriate interventions to offer.
And that is the fundamental. I mean, we are trying to offer the weakest of suggestions that you can, send someone to their entitlements, or you can be more sensitive in the kind of recommendations you make in terms of avocado versus other types of fruits and veg. But it is really important that we not be labeling and stigmatizing without having appropriate supports for people that are going to be identified.
Nadia has a question for all, and it's a big question, and that is, I'd be interested in knowing if the speakers have ideas about policies that our local, provincial, or federal governments need to undertake to address food insecurity. What would be the key priorities? And you've actually, each of you have addressed this in some way, but do you have any thoughts to respond to Nadia?
Lynn, why don't you go first?
Well, first of all, everybody tune into webinar number 2, but I think we've been actually looking for income-based solutions. The awareness that this is an income-based problem and income-based solutions are really important. We've been championing the basic income guarantee as being one of the viable solutions, but we also have heard on other webinars around really progressive social assistance rate increases, and for those with disabilities, as well for living wage, etc. So this is really an income story, and we're asking for all levels to actually be promoting that as as what's required.
Just to add to that, one of the things that I think is really, really important that we see start to happen both at the provincial and territorial level and federally is that food insecurity be identified as a policy outcome. So if I take, for example, the initiative now starting to ramp up federally for a poverty reduction strategy, we want to see that strategy include among its goals to reduce the prevalence and severity of food insecurity in this country. And I would like to see that strategy designed in a way that they actually measure and monitor food insecurity to say how well are we doing. So, as Lynn said, we and others have done research that points very, very clearly at the sensitivity of this problem to income-based interventions. But what we haven't been able to find too much evidence of are policymakers at the federal or provincial level who are taking on the challenge now of designing interventions that will actually move the needle on this problem. So I think part of what we want to see going forward is more deliberate action to change the rates of food insecurity, and presumably, I mean, if you buy our arguments that in fact these relationships are causal, that by changing the rates we can expect to see a change in people's health.
Interesting, thanks. Pat asks, so referring back to some of the discussion a few minutes ago, if you don't recommend screening for food insecurity amongst hospital patients, do you still recommend asking the question about monthly challenges of making ends meet?
Carlotta, can you comment on that?
I was waiting for one of you to. I think that a simple question that can be asked upon admission to hospital that would be beneficial, not just from my dietetic perspective, but for other healthcare professionals to understand what the barriers might be for that patient after discharge. So I do think that it's a worthwhile question to ask to understand if poverty is an issue for that patient. So we have more of a full understanding of who that patient and their experience upon discharge. But it isn't something I think that's routinely done in using a valid question like that. So that would be a big change into the future and something we could advocate for.
I'm going to continue now with another question by Pat. And so what to do about the CCHS? Should we consider a shorter question so that they choose it as an option, so that we get some more regular measures, and how to lobby for it to be mandatory always?
I think that we need to see food insecurity being included as a core, mandatory part of measurement on an annual basis until this problem is under control. I would submit that with more than 4 million Canadians living in households affected by food insecurity, this problem is out of control. And until we get it down to something that is more acceptable, like, I don't know, 4 or whatever, I don't know what that number would be, but one heck of a lot lower than 4 million. I think until we see any kind of substantial move, we need to be measuring this thing annually. And for that, it has to be mandatory, because we can't leave this to the whims of provincial and territorial governments to decide whether or not it's a priority for them. It should be a priority for all of them, but to circumvent that, it needs to be mandatory. As for the discussion about whether it should be shorter or not, this questionnaire is already very, very short for most people. Yes, there are 18 questions, but there are skip patterns built into that module, so that if you're not food insecure, if you're not showing any indications of food insecurity, you only get asked a few questions and then you're dropped out of the module. So for most people, this thing will take less than 1 minute. It only starts to get closer to 5 minutes if you're interviewing someone who is in a severely food insecure situation and they have something to say for each of those 18 questions. But for the vast majority of Canadians, this thing is very, very short. And so I think it's not the length of the questionnaire that is the obstacle to regular measurement right now. It's a lack of recognition of the importance of this as a public health problem, and a lack of commitment on the part of provinces and territories to do due diligence at times when it's been made optional. But given the opt-outs that we've seen over these last few years, I think there's no question this thing has to be made mandatory now, because we're not going to get reasonable tracking, and we've got a very serious problem on our hands.
Very interesting. We have a question and a comment from Fiona. First of all, she says that the Ontario just announced that it's going after a provincial food strategy too, and food insecurity appears to be the driver. Actually, I added comment from Fiona is that the draft federal national food strategy should be available soon for public input, and food security will be part of this. So you might want to respond to the draft document to add details. So thank you, Fiona, for those comments. Did anybody want to respond to those comments?
It's Lynn. I guess Val and I spent a lot of time talking about whether or not we should even weigh in, and whether the position should be that a food security or a food strategy should not include food insecurity, because it could be so confused with food as an outcome. And I think all the food strategies have actually included food insecurity and tried to have some careful wording. So I would just be hoping that we could make sure that we are not confusing the issue in the food strategies, but and yet they actually do recognize that because of financial constraints, there are large numbers of the population that are not able to access food.
Thanks, Lynn. Nairn has a question for each of you, or all of you, I should say. Yeah, the question is, will your team be involved in evaluating the basic income pilot test in Ontario?
I sincerely hope so. We're very, very happy to see that food insecurity has been identified as one of the outcomes of interest for the basic income pilot in Ontario. If anyone invites us to participate in the work around the evaluation of the pilot, we would be delighted to do that. But if anyone's listening, my email address is readily available. Please call. I would love to participate in that evaluation process, but it's for the province to figure out how that evaluation happens, and it's not something that we as outsiders can kind of insert ourselves in. But we're really, really pleased that they have so clearly named food insecurity as a consideration, a concern, and one that they expect to see some impact on with the basic income.
Interesting. I think we've got room for one more question here. We're at 37 minutes past the hour. Linda asks, could the lower sodium intake by food insecure individuals be because they are just eating less food because they can't afford to have enough food? buy enough food?
I don't think that's what that finding is. First of all, it's important to keep in perspective that while those differences are significant, statistically significant, the differences in those bar graphs are fairly small. And in terms of the bigger scheme of things, those are fairly modest differences. If you are interested, we'll certainly make the resources that we've cited in this webinar available going forward, and you could take a closer look at the findings. But I think we're probably just seeing differences in terms of food selection processes more than we are seeing the effect of lower energy intakes overall amongst that group. I don't believe that's what's happened there. We've done some analysis that have taken into account the energy content of the diet, but I would say that these are just small perturbations that associate with differences in food selection.
Great, thanks. Now, in the interest of time, I'm going to thank everybody for participating in this webinar. Thank you, everybody, for your questions and comments. There are a few that we did not get to. We'll be sure to cover those off in our post-webinar reporting. And I wanted to ask Val, Annalyn, and Carlotta, do you have any last thoughts before we close?
Well, I'm happy to go first. Just to first of all say thank you all for hanging in. Also, as Lynn said earlier, if you haven't looked at our earlier webinars, if you're interested in this issue or you want to help other people become familiar with this issue, please look at webinars 1 and 2 as well. They're available online. You can get them through the Proof website, and eventually number 3 will appear there too. Lynn, Carlotta, do you have any last words?
Just 2 things. One is to thank Craig and CDPAC for actually hosting this trilogy. And second, over the last 3 webinars, I just wanted to underscore how important I think it is to have our practitioners participate. And not only in the audience, but certainly like Carlotta and Pat and Suzanne before, and Tracy. I mean, these are really, really important. This is why we do the work, is so it can be of use to those that are actually in the field.
Thanks for that.
And I'll, I guess, go last. Just want to thank everyone for the opportunity to present today, and I hope you can take these messages that particularly Lynn and Val shared around the issues of food security and share this more with healthcare providers, because I do think this is a big upcoming area of work and lots needed to build understanding for our healthcare providers about this issue and implications for our patients. And as I try to share in my presentation, the differences between malnutrition and food insecurity and understanding these as distinct issues, and hopefully we can work forward into the future on addressing both of these issues in tandem. Thank you.
Thank you so much, Val, Lynn, and Carlotta, and thank you very much for all of you in the audience for your attention. We will be following up with a very short survey, and I hope you'll respond, as it really does help us learn how to continually improve our webinars. So thank you to all, and goodbye for now.